Good morning, ladies and gentlemen. Welcome once again to Health Committee. I'm glad to see everybody here this morning. And pursuant to Standing Order 81.5, Supplementary Estimates C 2009-10, Votes 1C, 5C, 10C, 25C, 40C, 45C, and 50C under Health referred to the Committee on Wednesday, March 3rd, 2010, and pursuant to the Standing Order 81.4, Main Estimates 2010-11, Votes 1, 5, 10, 15, 20, 25, 30, 35, 40, 45, and 50 under Health referred to the Committee on Wednesday, March 3rd, 2010. We will be engaging in the estimates once again this morning, and I want to say a special welcome to our witnesses this morning. From the Department of Health, we have Morris Rosenberg, Deputy Minister. Welcome once again, Deputy. We have Glenda Yates, Associate Deputy Minister. Welcome. We have Mr. Alfred Sang, Chief Financial Officer. Welcome again, Mr. Sang. From the Public Health Agency of Canada, we have Dr. Butler Jones, Chief Public Health Officer, and again, welcome, Dr. Butler Jones. And we have James Libby, the Chief Financial Officer, at our table once again. And we have Mary Chaput, Associate Deputy Minister. Welcome to our committee. So this morning we will not have opening comments. We had them yesterday. We're going to right into the question and answer period to give you ample time to cover all the questions that you need on committee. So we will have our 7-minute round to begin with, beginning with Dr. Duncan.
Good morning, Madam Chair, and good morning to all the witnesses, and thank you so much for coming. Before I begin today, I'd just like to once again raise the unacceptable TB rate among our Inuit, 186 times that of Canadian non-Aboriginals and among First Nations, which is 31.4 times higher. And this risk is similar to some countries in the developing world. It's unacceptable. And I'm wondering if we would like to consider bringing Dr. Gully back to look at this.
Maybe I can just start, Madam Chair. Dr. Gully, I'll be happy to bring Dr. Gully back. Dr. Gully is with us not just for H1N1, but is providing public health advice generally to First Nations and Inuit Health Branch, and obviously we'd be happy to find an appropriate time to explore that issue. I would say if you would like, we can address the issue a little bit further this morning, and I'd ask my Associate Deputy Minister Glenda Yates to perhaps
I
speak
think
to this.
I'll leave that for
Okay.
Thank you. I'm going to come back to knowing that he's going to be there. That gives us great faith that this will be addressed. What was the initial, I'm going to come back to CHVI. What was the initial driving reason for CHVI?
Canada was very much interested in being part of the global efforts in the development of vaccine. At the time when that started, one of the deficiencies or one of the challenges was trial lot production facilities for clinical trials. That's why, as part of Canada's CHVI strategy, that was one of the areas of focus. In the subsequent time, that has now been addressed. So those resources are better used elsewhere.
Was the driving rationale the fact that a number of clinical trials failed for reasons related to clinical lots manufactured under inadequate conditions rather than because of the actual design of the vaccine?
No, there's tremendous, as you can appreciate, there are tremendous challenges in the development of a vaccine against the retrovirus. Particularly, one of the key concerns is that you don't want to actually stimulate, since the action of the retrovirus is to create challenge for the immune system, you don't want to actually recreate a challenge to the immune system in otherwise healthy people. And so the complexity of the vaccine, as we've seen in multiple clinical trials, they've been very challenged, and even the one that has some promise still had very marginal benefit. And so the issue is finding good models for vaccines that might have the prospect of working. There's been multiple trials that have not worked well, and it's not about manufacturing, it is about the basic vaccine itself.
I guess I'm still struggling with the fact that a due diligence study was undertaken in 2009 after the government announced the partnership with Gates in 2006. We know the scientific committee met in May of 2009, and you kindly offered to provide dates of subsequent meetings. So what it looks like is the International Committee was invited in May, and at the same time this parallel process was going on. And I think the focus you have made it on capacity in the world shouldn't have been the quality of manufacturing.
The process itself was we were proceeding on with the process. As it turns out, none of the applicants crossed the bar. At the same time, given the time elapsed and given the recognition that things had changed in the world, Gates commissioned a study to look at capacity, just again to make sure that we're on the right track. That turned out to illustrate that in fact capacity had increased and the needs and the circumstances had changed. So since we did not have a successful applicant and the capacity issue was now addressed, it seemed much better to use that money elsewhere. Whenever that takes place, it's kind of like arguing that we could have done something different about H1 because H1 arrived in April, and surely we should have known back a year ago that it was going to, a year before that it was going to be H1. You only know what you know as you know it, and it's not. There was in fact reviews that identified when we started the process that there was this need. By the time we got to that point last year, there was no longer that need. The world changes no matter what we do.
If we look at Oliver Wyman's report, do you think there are any problems with the study?
They, in the report itself, identify what the limitations are, but there's clearly sufficient evidence there about what the circumstances have changed that have convinced people that, in fact, what we need to do now is to redirect those resources to other areas of HIV vaccine work.
The document does begin with a disclaimer. Do you think it's acceptable that the document is in part based on secondary information that was not independently verified?
For this purpose, yes. You can't do everything, and you can't follow everything, but certainly for this purpose, yes.
The project objectives are as follows. Primary emphasis on assessing physical capacity, not quality of the capacity. Where possible, capture data on prior GMP experience as proxy. So the study was to assess the physical capacity, not the quality of the capacity for manufacturing clinical trial materials for HIV vaccines. It's my understanding that it was the lack of manufacturing facilities meeting stringent regulatory requirements of vaccine manufacturing that initiated the CHVI program. I mean, these vaccines are tested on living people, and we have to ensure the safety of all vaccines. Do you think that study should have included the quality aspects of manufacturing, yes or no?
These production facilities are all subject where they are to the usual kinds of regulatory controls, as would a facility should we were to build it here. There's no guarantee that if we built it here that it would be, in fact, any better than anywhere else. That's just a practical reality. The point being is that for the clinical trials, for ethics reviews, for all of these purposes, they have to meet those standards. So it's in the scientific world, and you're not going to you're not going to be able to cover 99.9999% of every issue or every question. The point is that capacity is there, it's with reputable organizations, and the feeling is that there is sufficient capacity now to address what we need going forward.
Thank you, Dr. Butler. Monsieur Mallow.
Thank you, Madam Chair. Unfortunately, this morning, I will have to come back on what was said here last Tuesday by Michel Boudreau, the Director General for Natural Health Products. I already said last Tuesday that her figures did not seem to correspond with those we had been presented with by the Research Service of the Library of Parliament. And I'm going to quote Ms. Boudreau. There are only 193 requests for certification left in the backlog, end of quote. This means, Madam Chair, that there is backlog and everything else has been completed and taken care of. So in the stack, all that's left are to process 193 requests. All the other requests have been either approved or denied. That's what it means. Another quote from Ms. Boudreau. So we are very confident that we are going to meet our deadline for the end of March. Further, we are confident that we're going to complete all the other requests, that is 3,000 further applications by December 2010. So we have two stacks, the stack of backlog and the stack of applications after April. She said this is all that's left to process. Ms. Boudreau said 3,000 are left to process, but the Research Service of the Library of Parliament said there are 10,705 applications left. So I would ask Mr. Rosenberg, what is the real number? Is it 3,000 or 10,705? Thank you for your question. Ms. Boudreau is here, and I will ask her to clarify the difference between the numbers presented by the Library of Parliament and what she said here last Tuesday.
Yes, Merci.
Oui, je vais certainement tenter d'éclairer les chiffres.
Certainly, I will try to clarify the numbers, and I understand that these can be confusing. Now, we use two different expressions. I'll use these expressions in English because I think it's easier. In French, it's the same expression. In French, we have addressed, and in French, we say traité. In English, addressed means that either the license has been granted for the product or it was rejected, or the application is being processed, that the file is active and that the evaluation is ongoing, and we also may have requested more information to process that application. This is what addressed mean, and again, in French we use the word traité. So the other day when I said we had 193 requests or applications left to traité, to addressed, this is not, addressed is not the same as completed. Tuesday you used the word completed. If I did, I apologize. There is a distinction. 193 applications are still open, if you will, which still need to be processed. The total figure is 3,098. That is the balance, 3,098 minus 193. All of these applications will be finalized by the end of December. But by the end of December, I cannot tell you that we will have completed the 9,764, which does not only include the backlog, but also the regular workload. So that is the distinction. I know it can be confusing because two different expressions are used. When I asked the minister the question on Tuesday, on February 10th, 2009, she told us that she would completely eliminate the backlog, reduce it to zero. So, and what she said in February in 2009, again, was that by March 31st, the backlog would be eliminated. And you said yes. Do you still maintain that today? Do you still maintain that the backlog will be completely eliminated by March 31st? No. I would ask you to refer to what I said a few moments ago. The backlog will be addressed before the end of March, and the backlog will be completed by December of this year. Now, what is the actual deadline? It seems the deadlines are being moved forward all the time. Originally, we heard of December 2009. You have internal rules. That's been moved up to March. Now it's December. I think that people have a right to know what exactly is your real schedule and your real budget. These are legitimate questions. We have to deal with these outright contradictions and statements of vagueness. Can you clarify this for us? There are jobs at stake. There is revenue at stake as well.
Need her to answer the question.
Yes.
Thank you. Calm yourself.
Je peux vous dire que depuis que moi je suis là,
Since I have been appointed to the position of Director General for a year and a half, the deadlines have not changed. The first deadline, 2009, is the only one contained in the current regulations. It applies only to projects who had drug identification numbers, that is, products which were regulated under the former system, which has now been transferred or subsumed into the new regulations. And that's the only deadline you will find in the regulations. So the department told industry that there was a very clear deadline which we have established. It is an internal deadline. As I said earlier, we are on track to address the backlog by the end of March, and this is the deadline we have included in our documents for a
c'est encore le même échéancier qu'on annonce aux gens, ça fait plusieurs mois. On est bel et bien aussi sur la...
now, and we are also on track to complete the backlog, 3,098 applications by December 2010.
We'll now go to Ms. Washale-Lease.
Thank you, Madam Chairperson, and thanks to all of you again for being back today. I want to go back to Dr. Butler-Jones, as he would expect me to, on the Canadian HIV vaccine initiative, and refer us specifically to the process pertaining to the 4 bids for the actual vaccine production facility. On February 21st, in a very long conversation that I had with Dr. Rain Engelhardt and Mr. Stefan Sternthal, who is the director of the Canadian HIV initiative, it was indicated to me that all 4 consortiums who had placed bids in this process had received full explanations for why their bids were not accepted in the spirit of complete transparency. To the best of my knowledge, those full explanations have not been forthcoming. Can you table for us today the detailed explanations that were given to each of these 4 bidders, or at least tell us if that request has been met, or that promise has been fulfilled?
The same as for other bids or for research bids, it would not be appropriate to table what it is. Should they wish to share that with you, that's up to them. But we would keep that in confidence. We don't share that with we share that with the individual who placed the submission. Those discussions have taken place, and further discussions will be taking place.
But, okay, my question is, it's hard for them to share anything with us if they haven't been given anything, and the promise for full, detailed explanations does not appear to have been fulfilled. When will it be fulfilled? When will each of the 4 bidders get a detailed explanation of why their bid did not meet the requirements?
They've all had detailed discussions. Whether their perception of it is the same as that's a different question, but the discussions have taken place with all of them, and they are continuing.
So you haven't given a detailed written explanation to any of these 4 bidders who put in upwards of $2 million in total to meet the process as set out in 2007.
Our responsibility is to make sure to understand where there were deficiencies for them, and those conversations have taken place. I'm not sure about what was put in writing to them or not, but those discussions have taken place, and as I say, they will continue as they wish.
You don't find it strange that they wouldn't receive detailed written explanations after such a long, costly process, for why they didn't meet the requirements of the program? You don't find that strange?
They've been told what their deficiencies were.
Okay, we'll leave it at that.
And since there's no reason to, there's no reason, because there is no successful bid and we are not proceeding, it's not like a new bid will make a difference. If there was to be a new bid, then the detail would be more. But the detailed discussions are ongoing. They've had high-level discussions. They've had various levels of detail, and the information has been shared with them. And that will continue to do so.
Let's leave it at that, because, in fact, that is not in the spirit of any kind of transparency and full disclosure that anyone would expect in the field, or that was promised and indicated to me was a commitment that was fulfilled by the head of this program and a leading scientist at the laboratory in Winnipeg. Let me go on to this further to Kirsty Duncan's questionings around the study that has been used as one of the excuses for the termination of these bids. Are you aware of a study that has been done to critique the Gates study? And in fact, I want to refer specifically to a study done by Don Gearson, who is a leading expert in this field. He has his PhD from McGill, professor of biophysics and biochemical engineering at the University of Western Ontario. He is president and CEO of New Facts Incorporated, and he has done on March the 8th a complete analysis of the Gates study, and in fact indicates that this study is fatally flawed by its failure to place priority on the quality aspects of clinical materials manufacturing. Are you aware of the importance of good manufacturing practices and what that means in this context?
I am aware, and that is obviously a criteria. Both the Gates Foundation and ourselves are very conscious of the need for quality science, and the assessment was that this was sufficient information. The issue of quality is one which is always there in terms of good manufacturing processes, quality manufacturing processes. That's always going to be there, and it's not going to happen without that. The deficiencies in the proposals, the Canadian proposals relate to that. So it really is something which for the Gates Foundation and for ourselves, the information is sufficient given the standard of laboratory practices, given the standards that all the laboratories are expected to provide and to do in terms of good manufacturing processes, that was not an issue. And there will always be an exceptional view, but the general view was clearly that this was sufficient.
Given the scientific questions, the questions based on good scientific merits have been raised about the Gates study, and given the fact that the Gates part of this whole proposal was only $22 million out of the $139 million in total, so only a portion of that against the $88 million for the facility. We're talking about a fairly small contribution in the face of a promise by the Canadian government 3 years ago to provide leading-edge production facility in this area. And given your role as the Chief Health Officer of Canada, are you not questioning at all how this study was suddenly emerged by Gates under the auspices of the Gates Foundation on July 2009? And are you now not, based on this strong representation by scientists like Dr. Gearson, questioning the process and the study, and in fact sounding the alarms about the entire process? Is it not your obligation?
Your time is just about
as Chief Public Health Officer to do that?
My obligation is to provide the best advice possible, both scientific and in matters of public health, and to, as the deputy responsible for the Public Health Agency, to manage its affairs both in policy and finance. Those are my responsibilities. I have seen this. I've seen this evidence. I've been part of the discussions with the Gates Foundation and with the scientists. And it is my assessment, along with the Gates Foundation, that in fact this resource could be better spent elsewhere at this time, given the capacity that's developed in the world. I have to take evidence as it arises. It could have arisen, I mean, for example, throughout the H1 that we've been having things, we saw things that rose on a certain date. It wasn't 3 weeks earlier, it wasn't 3 weeks later. You deal with it when it comes. This was part of additional due diligence beyond the original. Given the space of time, it was appropriate to assess what the capacity was in the world and how it had changed, and the assessment was that the capacity had changed. And so therefore, a re-examination, given that none of the applicants passed the bar, they all had deficiencies and would require some major work in order to change that, whether either in a new process or in a revised process, and that the capacity is now out there. It is, in my clear assessment, and those who advised me, as well as the Gates Foundation, that in this case it is time to move on and use those resources for something else to move the agenda around an HIV vaccine.
Thank you, Dr. Butler-Jones. Ms. McLeod.
Thank you, Madam Chair. And I'd like to, first of all, start by building on the my colleague's comment around tuberculosis. And of course, not only is tuberculosis an issue, but we know that there's significant health disparities with our Native and Inuit communities. And of course, we obviously know that, housing, poverty, water, safe drinking supplies are part of the solution. But certainly, First Nations and Inuit health have a critical role to play. And I noticed that there's some changes in terms of where you're going. And first of all, I'd like to focus in on, you're talking about 237.3 to stabilize primary health care services and non-insured health benefits. So I'd like to hear a little bit more about what that will involve, how much of it's primary health care, how much is really related to drugs, eyeglasses, dental care. So I guess that's my first focus.
Who would like to take that question? Ms. Yates?
Thank you very much, and thank you for the question. It is the case that we have significant challenges in terms of supporting and improving health services and health status on First Nations Reserve. And I think reducing the inequalities that we see is a very significant priority for the First Nations and Inuit Health Branch. And it's to that end that we have a number of programs. You mentioned the non-insured health benefits program, which we are by which we provide a range of drugs, dental services, and other services to people living on and off reserve. And the estimates that you mentioned, the incremental amount there is $305 million that was put in over the in budget 2009 over the 2 years to help stabilize that program. In addition of those stabilization funds, with the $440 million that over the 2 years that was announced as part of the Economic Action Plan, there's $135 million that was for infrastructure. So we have a significant number, around 200 communities that are very isolated, by which we have nursing stations and nursing residences often to support the staff who stay there. And we had some significant ability in that with those funds to move forward on our capital program to construct and renovate and modernize some of those capital facilities as well. There's also in Budget 2010 $285 million over 2 years for Aboriginal health programs in some of the prevention and treatment areas such as diabetes, youth suicide prevention, maternal and child health. So we were very pleased that these are investments we think that will be very important as we move forward to try to reduce the inequalities in health status that we see.
So the additional money, not only is it providing additional capital infrastructure, is it changing what's available in each community, for example, in terms of non-insured health benefits or primary care services, or is it more focused on ensuring some reasonable accommodation?
In terms of the non-insured health benefits, it is a program that has rising costs every year. Typically that's because we're always adding new drugs, for example, so there would be an expanded range of drugs, but it's not a major policy expansion. It's simply that as new drugs come on the market and are available and are assessed, they are added to the formulary, for example. And in addition, we have increased population, so we are covering more people because this is a growing population. So that leads to increased costs as well. Where we have been able to have some new programming in recent years and are able to continue that with the $285 million in this coming budget is in the area of youth suicide prevention and maternal and child health. These are programs that have been started in more recent years, and this money will allow us to continue those, to refine them, and to make sure that we have, in addition to the very important treatment services, some services on the prevention side as well.
Great, thank you. And to shift directions, I think I like to explore InfoWay Canada frequently because many people believe that it is absolutely critical to create success across Canada in terms of our electronic health records and where technology is supporting our communities, our physicians, our hospitals, and ultimately, you know, or most importantly, of course, is our patient and how we provide care. I know that certainly the audit federally was very positive. I think, you know, people's perception of what is happening due to some of unfortunate circumstances within some of the provinces, perhaps they are not as aware of the good work. So I would really like to hear some more about Health InfoWay, where we're going, and how it's moving forward.
Thank you. As was mentioned, there was Federal Auditor General did an audit of InfoWay, and you know, while no audit is ever perfect, I think the Federal Auditor General found that InfoWay was largely on the right track. There were a few recommendations made with respect to some of its management practices. InfoWay did issue a management response and an action plan to take those to move forward on those recommendations, and really on that basis, in Budget 2010, the government freed up the $500 million that was part of the Economic Action Plan for Infoway. And in fact, there has been a lot that has been accomplished. Just to give you a sense of some of the initiatives with respect to moving towards the benefits of electronic health records. 3/4 of X-ray films. Anybody who's ever had to go to a hospital and wait for X-rays, even though X-rays may have been taken before, 3/4 of X-ray films have been replaced by digitized images in the public health system. So the accessibility of those X-rays, the reduction of needless duplication, I think is a very important part of this. The development of drug information systems, which are a key building block of electronic health records, are in place in BC and Alberta, PEI, and Saskatchewan, and that's really important. I think one of the main benefits of the electronic health record is getting information that will avoid error. And if you can get a sense of what has been prescribed and what contraindications are, and avoid some of the written script where there are errors in terms of interpreting it by pharmacists, I think that's an important benefit of an electronic health record. All communities north of 60 are telehealth enabled or are in the process of implementing telehealth capabilities. And again, given the nature of Canada and the remoteness of a lot of our communities, the importance of having access to telehealth is huge. In Alberta, 20,000 authorized healthcare providers are actively using the electronic health record, and this has helped Alberta start to implement a chronic disease management system. So those are just some of the examples. Infoway continues to work with the provinces and territories. It has I think the Auditor General found a very prudential funding arrangement. It needs to see sort of real proof of sound implementation plans before money will flow to the provinces and territories.
Thank you, Mr. Rosenberg. And now we'll go into our second round. It's 5 minutes question and answers, and we'll start with Dr. Bennett.
Thanks very much. I wanted to focus a little bit on maternal and child health, and the Prime Minister's commitment is that a priority for the G8, and wanted you to explain how, with that commitment, how in the mains on 13.7 that $900,000 has been cut from nonprofit international organizations in support of their projects and programs on health. Can you tell us that which projects those were, or table them, or let us know that none of those are to do with maternal child health?
Yeah, I can't give you the list today. This was coming. I think you're referring to some of the reallocations that were made as a result of strategic review last year. Is that
13.7 in the mains?
Yeah. If you just give us a second to have a look at that.
It's in the grants. It's for next year.
Sorry, thank you. I'm informed. We will provide you with more details, but I am informed that none of those cuts deal with maternal health issues.
Okay, and in I guess in our domestic record on this, in terms of setting it a priority, obviously there's some concerns that the Centers of Excellence in Children's Well-Being have been cut, that the Centers of Excellence in Women's Health have received informal cuts, much more narrow mandate. But I guess it's mainly in our domestic record on infant mortality, maternal mortality in our First Nations and Inuit, that I guess I'm concerned that we are seeing 70 million transferred from the community care programs for First Nations, 50 million transferred from Inuit primary care, and I guess I would like to know how that is justified, but mainly, we are still having trouble having the data on infant mortality in terms of First Nations and Inuit. We know it's higher. We know when you average it in, it puts Canada worse than Cuba in infant mortality. And I guess I would like to know when you're anticipating having the data, and what would be the strategy in terms of what to buy when and how that we will reduce the infant mortality in our First Nations and Inuit, as well as all Canadians in remote and rural areas.
Yates, thank you for the question, and there are two parts, and I'll address the data part first, and then speak to the programming section. I think we all share the concern and the challenge about getting better data, because it does enable us as a country, whether at the local level or at a regional level or a provincial level or at a national level, to actually understand where the fine points are and where the interventions, where the challenges are and where the interventions should be targeted. As you mentioned, we have not, unlike some countries, we have not gone with First Nations identifiers or ethnicity identifiers. The U.S. has taken a much different approach in their data collection than we have in Canada. And at this point, really, the strategy is to work locally and to work nationally with First Nations, national Aboriginal organizations, and to work locally with bands and regions to understand their willingness to have data collected and to work with them so that there is some understanding of the importance of having data that will give us better information on a First Nations basis. Having said that, working with organizations such as Statistics Canada or the Canadian Institute for Health Information, there are some ways of writ large trying to estimate some of the gaps in, for example, infant mortality, and we do know that there are some higher rates, and we are working on with those organizations and with national Aboriginal organizations to continue to improve the data. Having said that, what we do know is that this is an area of priority and of urgency, and we do have a maternal child health program, and one of the estimates reveal the reductions that you mentioned, because they don't reflect the $285 million over the next 2 years that was announced in Budget 2010 for 5 programs, one of which is the maternal child health program. So in fact, there will be no reduction in funding to that program, although, as you say, that's announced in the budget, so it's not reflected in the estimates before you. So with that money, we have, you asked about the strategy. There is a multifaceted strategy. I think we always understand the complexity of working with communities and individuals on maternal child health. Some of the program elements that have been in place are things like home visitation, having community workers doing screening, for example, in terms of high-risk mums, and trying to both prenatally and then postnatally support those particular families and individuals. There's been an effort to integrate culture into care, so working again to adapt through elders and through translation into local languages, for example, some of those documents and supports and guides that we have. There's case management, again, to help families who might be high risk, who have specific needs, to try to help those targeted families access the services they need.
Okay, thank you, Ms. Yates. Time is up. We'll now go to Mr. Brown.
Thank you, Madam Chair. And just a follow-up on some of the questions that Ms. MacLeod answered. I too was interested in the Canada Health Infoway, and I appreciate the benefits. I'm just a little curious about how we monitor where it's going in the partnerships with the provinces, because every year we see these budget allocations, and in past budgets we have more money going towards the Canada Health Infoway. And I was curious, so I asked the CEO of our hospital in Barrie, Jana Scott, what investment she's seen in e-health come down from the province, and she's told me they haven't seen any e-health funding at our local hospital. And so I guess I was curious, when we go back to our communities, what evidence should we be seeing of the federal investments in Canada Health Info? You mentioned to Ms. McLeod the digital copies of X-rays. Are there other examples like that? And would I be seeing that at my regional hospital? Would that be the result of federal investments into Canada Health Info?
Thank you for the question. I think one of the realities of Infoway, and it really does go to the funding model, is that funding isn't flowing across the country on an equal basis. And the reason that funding isn't flowing across the country on an equal basis is that Infoway, as part of its prudence in how it manages its money, will only flow money where it feels that provinces have met a threshold of readiness to implement projects. So you've got some provinces, Alberta and PEI, I think, are examples that are further ahead than others. You've got others. Ontario would be an example right now for a variety of reasons. That's less far ahead. So not everybody will see all of the benefits that I talked about in an equal way. The idea, though, in Infoway says that the country will be very close by the end of this year to having 50% implementation of electronic health records. Again, that will not be 50% across the board, but it will be 50% looking in various jurisdictions. Obviously, the idea is to get the entire country on a basis of electronic health records, to establish standards in a way that when people move across the country, there will be portability of those records, even though the systems are going to be built on a provincial basis. And that, by the way, is very similar to the way other electronic systems in other industries have evolved.
And I love the goal. I guess I'm curious to know where we are. And you mentioned, PEI and Alberta being ahead. Where are we in Ontario? And as an MP that resides in Ontario, I'm very curious, what progress could I point to in Ontario where we've seen federal investments have success?
Well, I mean, Ontario has been a little bit more problematic, as you're aware, because of some of the difficulties that have occurred initially with Smart Systems Ontario and then more recently with eHealth in Ontario. But one thing I will say, there is one very good example, and that is the Ontario Telemedicine Network, which has over 2,000 healthcare professionals now delivering care to over 660 rural and remote sites throughout the province. So in terms of the progress that I mentioned generally with respect to telehealth, I would say that Ontario is, in respect to that aspect, among the leaders. I would also say that in Ontario, following the much publicized concerns and the Provincial Auditor General's report around eHealth Ontario, I know that new management's been brought in. I know that a former federal deputy and former head of the board of the Ottawa Hospital, Ray HESA, who has an excellent reputation as someone who can come in and bring and essentially put big informatics systems on the right track, has been working with eHealth Ontario, and I'm hopeful that within a reasonably short time you'll see real progress in Ontario.
Would it be unrealistic to hope that you mentioned the 50% implementation rate? Is that unrealistic to hope for by the end of the year in Ontario?
I think it may be. That's a national rate. I'd have to get back to you on where we would be with Ontario. I don't think you'll be at 50% in Ontario. I think we're actually quite close to 50%, even though in the Auditor General's report the actual metric was somewhere just below 20%. And the reason for that is in the way that 50% is calculated, every element of an electronic health record has to be in place. So even if you've got 10 elements and 9 are in place and the 10th isn't, it's not there yet. But in fact, Infoway and our discussions with them are quite confident that we will actually see very significant progress in getting to that 50%.
Thank you. I'm sorry, Mr. Brown. Thank you, Mr. Rosenberg, and we'll go to Monsieur Mallow.
Madame la Présidente, l'engagement de
Thank you, Madam Chair. The commitment of Minister Aglukak with regard to completing the backlog by February 10th, 2010. I'll read this in English, so I'll quote her.
Eliminating the backlog by March 2010. Donc, la ministre, ce qu'elle nous dit, c'est que son objectif.
So, the minister is telling us that her political commitment is to eliminate the backlog by March 2010. Following what Ms. Boudreau said with regard to the objective of the Department of Health was to begin to process all the files or applications in the backlog by March 2010. Mr. Rosenberg, how is it that the political commitment of the minister does not reflect the official's position, and is it common practice that there is a gap or disconnect between the objective of the directorate and the political commitment made by a minister? I will begin by saying that Ms. Boudreau explained that you have to understand the meaning of the words or expressions which are used. I do not intend to provide you with false information. This is a very complex area, and the department and the Natural Health Products Directorate are very clear, and they are there for all to see on our website. There is information there which has been there for quite some time now, and this information contains warnings for the entire community, that is, those who sell the products and those who buy them. The information also includes timelines. If the committee wishes, we can table this information with the committee, even though it's available on the website. Again, we are trying to deal with a situation which does present some challenges. We're trying to be as transparent as possible. I can't give you any other response. You said that the deadline or the timelines are on the website. Ms. Boudreau, a little earlier, talked about the deadline, saying that all the backlog will be taken care of by December. What is the deadline for the overall backlog, and what funding do you have to process all these applications and to deal with the regular workload as well?
Juste pour revenir peut-être à la question.
Thank you. I just want to come back to the question Mr. Rosenberg addressed. Certainly, we have information on our website, and we posted some more information on the website several months ago, and we have information for industry, the sellers, and buyers. We have those three deadlines, 2009, March 31st, 2010, and December 2010. As for what will be left over, 6,000 applications or so. We don't have a specific timeline, but we are in the process of processing applications which include monographs, and we are our aim is to complete each of these applications within 60 days. It's a very fair performance standard. As for the more complex applications, products which contain certain ingredients and which tout more sophisticated health benefits, for these products and those applications, we are in the process of developing with our advisory committee, which I talked about the other day. We're establishing performance standards which are reasonable and fair. Performance standards between 90 and 180 days. Again, this is very respectable. 180 days is a figure which was suggested to us by industry for the more complex applications. I have to admit that we're not quite there yet now. As Mr. Rosenberg said, this is a very complex field. We had to process several applications, as you know. 47,000 applications were received since the regulations were introduced. we have completed about 37,000. So really, we've done a huge amount of work. Up to 80% of these applications have been completed. And as for the performance standards, we're getting there, and we think we will be able to implement them in a few months with the help of the advisory committee, which is giving us its input, of course.
I'll go to Mrs. Davidson.
Thanks very much, Madam Chair, and thanks very much to our presenters for being here with us again this morning. I want to change pace here a little bit and ask some questions about seniors. We know that we are certainly coming up to having a large percentage of seniors in this country, and I think that we've got evidence that shows us that falls are the most frequent injury among seniors. And we also know that many of these falls result in institutional placement and loss of independence, and all of these things give rise to a far lesser quality of life for our seniors. So with the number of older persons in Canada, it's projected to increase greatly from 4.2 million to 9.8 million between 2005 and 2036. And they're also estimating that the number of older persons who will fall at least once in 2036 is projected to increase to 3.3 million. When we look at these figures, they're staggering. And we also have seen evidence that falls can be prevented through a combination of interventions, including education on the risks of them, how to prevent the falls, exercise, those types of things. Can you tell me what the Public Health Agency of Canada is doing to address the issue of falls in seniors?
Thanks very much for the question. It is, all of us are aging. That is a good thing.
The lucky ones.
The alternative is not preferred. And as we age, the challenges in many ways do increase. And certainly as it relates to falls or aging, there are a number of things that can be done. Some of them, in some ways, it's actually quite simple. I mean, a lot of the falls are based on declining vision, throw rugs, tripping in the home, etc., not clearing sidewalks, not having sort of smooth transitions where suddenly you can't see the edge of stairs. I mean, even having strips on stairs so you can tell where the edge is. There are a lot of things that are fairly simple. So partly education, partly it's also around the municipalities and others in terms of creating age-friendly communities, and not just for the aged, but for all ages that make access and movement and exercise and all of these things that make for a healthy outcome. Later in March, 22nd, 23rd in Vancouver, there will be the first ever conference on seniors falls prevention, and that's being sponsored by us, as well as we've been involved in the development of what was an award-winning the Canadian Falls Prevention Curriculum Initiative. There's also e-learning issues, and in 2005 we had our report on the seniors falls, and we plan to update this in next year. Also, my report this year on the state of public health, each year has a theme, and this year's theme will be on seniors, and clearly falls prevention is just one but very important aspect, and again, it is something that we've demonstrated we can do something about. It takes a little thought and effort. It's not expensive, though, and it can make a huge difference to quality of life.
Thank you. I think that's commendable that we are definitely looking into these areas and definitely much needed as we look after the health of our and well-being of our seniors. Now, I have one more question, and it's regarding the Patented Medicine Prices Review Board. And when I looked at the main estimates, page 1313, I believe, here, you're requiring about $7.75 million for the compliance and enforcement of non-excessive prices for patented drug products, and this is an increase of about $704,000 for this particular program activity over the last year's estimates. How many public hearings do the PMPRB expect to conduct in 2010-11 in support of its mandate? And how does this number compare with the number of hearings held in the previous year? Are we increasing the number greatly? Is this keeping up with the backlogs and so on?
Thank you for the question. So just to be clear, the regulatory mandate of the Patent and Medicines Prices Review Board is to ensure that prices charged by patentees for their patented medicines sold in Canada are not excessive, and the role of the board and its staff is to investigate prices of patented medicines that appear to be excessive, and that may result in a report to the chairman for a possible hearing. Once board staff and the patentee have determined that the matter can't be resolved by voluntary compliance undertaking from the patentee. So currently there are several patented drug products which appear to be priced excessively, and board staff will submit a report to the chairman for the issuance of a notice of hearing in one or all matters if it's not possible to resolve these voluntarily. As I mentioned the other day in response to a question from Mr. Mello, there has been a change over the last while with respect to the way the practice of that board is carried out. I think that traditionally, going back to the mid-'80s when it was set up, most matters were resolved voluntarily. There has been a tendency later for more matters to go to contested hearing. So in 2009-10, the board completed 4 hearings and has issued to date 2 notices of hearing. And at this time, there are currently 9 ongoing hearings, 3 of which are at the decision stage.
Thank you.
Ms. Davidson, we're now going to go to Mr. Bagnall.
Thank you, and thank you everyone for being here. I just want to ask a bit about the services that you provide to residential school survivors. In Budget 210 commits $199 million to higher than expected funding needs to support the settlement agreement. So I know that some of that goes just to the fact that we owe individuals money, but the minister said some of that's going to services you provide to the mental health. And I'm just wondering what the breakdown of that money might be. Of the $199 million, how much is just going to survivors? How much is going to your department to provide counseling services, etc.?
Thank you very much for the question. The $199 million that is referenced in Budget 2010 includes $65.9 million that is the Health Canada portion of that. So that's for the Health Canada Resolution Health Support Program to be able to respond to the growing demand that we anticipate as a result of the Indian residential school process.
That's just for 1 year?
No, that's for 2 years.
2 years.
Because the $199 million is a 2-year figure, and so 65.9 million of that is for Health Canada.
For over 2 years, okay. And how much was that? How much did those services cost this year, the year before this $65 million come in?
I don't have the precise figures. Some of the services, the demands depend on the uptake, and the Truth and Reconciliation process has been a bit slower than originally anticipated. So it really is demand-driven in terms of when people come forward and seek the services. I have a note here that it was approximately $39 million in last year.
So over the next 2 years, it's just slightly, almost the same, a little bit slightly less, but per year.
Yes, and because it's a court-ordered amount, if it turns out that there are more people who come forward, or this is something we would have to respond to in a supplementary estimates way, but this is our estimate that would reflect the demand that we expect in the next 2 years.
But this is just for like counseling and health services and things for these individuals, right?
Yes, this is for the, there are a number of services here for mental health and emotional health support, including counseling. There's some traditional, using elders and others. There's a combination of services that are offered.
Okay. Just on a similar vein, different area though, and the 285 over 2 years, Budget 210 renews funding for a number of programs. You've mentioned it a couple times already, diabetes, suicide, the 5 programs, maternal health. How much, once again, how much, so that's 140 million for this year. How much was last year? Like, these are just extended programs. So I just want to know how much we spent this year or allocated.
The figure, in terms of the 142 million, it was a little bit higher this year. It is broken down for a number of programs. So for the community programs, we talked about maternal child health or youth suicide prevention. Those programs are all at the same level they were last year. There are 2 programs that over this period have less money, particularly in the Aboriginal Health Human Resources and some of the transition fund. So this current year's spending, I think, is about it's slightly higher than the 142 million. But the community programs, all of the treatment programs are at the same level, and we've done a very we think a good job in terms of increasing the number of Aboriginal students in various programs. So those are areas where we're moving money away.
210 is going to be 140 million. So you're saying this year, 209, 210 was slightly over 140 million?
Yes, that's right.
Just slightly over, about the same.
No, it was higher in the community programs, so maternal child health, youth suicide, some of the mental health programmings, those are all at the same level as they were this year. So those, we're still finalizing some of the details, but that's certainly...
But some other ones were higher this year.
Yes, that's right.
So it's actually a cut to those programs.
There were 5 years of funding, and in some cases, we felt that some of the transition programs we've moved on and have priorities elsewhere. So there are some areas where we have moved money.
Could you get us the exact figure later?
Yes, we're still in the process of finalizing that, but yes, when it's available, we can certainly make that available.
Thank you.
Thank you very much, and we'll now go to Dr. Carey.
Thank you very much, Madam Chair, and I want to thank the witnesses for being here today. I always find your presence to be very informative. I want to follow up with my colleagues' questions on the InfoWay, and I want to commend the government for taking a leadership role for electronic records. I think everybody sees the goal, and it's getting closer and closer. I know there's challenges with the patchwork system we have in Canada. I had the opportunity to read an article about some software being developed at McGill, how it would even work both ways, where the software could remind patients, for example, to take their shots of insulin on time. But it brings up an issue about privacy issues. And coming from Oshawa, there was a situation where electronic records, they were misplaced. And I was wondering, where is the privacy? Where's the role of the federal government in regarding privacy issues in development of these records? Is it something that the federal government, that's a jurisdictional thing with us, or do the provinces look after that, or is it a combination between the two? And how is that situation being worked upon? Because when that situation happened in Oshawa, where these records now electronically, you can condense so much information on just even a little stick. It's portable. It's really out. You can put that onto the internet. There's some concerns about that, and I was wondering what kind of progress we've had with that.
Thank you for the question. I'm going to start, but I may turn to Glenda, only because in her previous job as the president of the Canadian Institute for Health Information, she was very involved in some work that was ongoing that I'll mention. Privacy is an issue, obviously, with respect to any electronic system, especially a system that's dealing with the nature of personal information that you'd find on the electronic health record. And I think it's important to manage the evolution of this in a way that will achieve a number of goals in equilibrium. Obviously, we want to have the most efficient health record possible. We want to do it in a way that's going to be respectful of privacy, but we also want to do it in a way, and this is where the work, I think, is really important, that we can have access to aggregate information. Because there is huge value in having that aggregate information for the management of the health system to understand at a population basis or on a regional basis what outcomes are. So to give you one example of where aggregate information might have been helpful had we had an electronic health record at the time. Remember back a few years ago the situation around COX-2 inhibitors, Vioxx. And from what I've heard in the United States, Vioxx killed thousands and thousands of people, a lot of middle-aged men with strokes and heart attacks. I think it took a long time in terms of the kind of detective work to associate those conditions because, frankly, a lot of, middle-aged people might come into, or elderly people might come into hospital with those kinds of conditions. If you could have linked the drug interaction, in other words, what they were taking, with the fact that they were presenting with these symptoms, and then kind of done a search and determined that there was a pattern here, it may have been possible for regulators in the world to have moved much more expeditiously with respect to dealing with that. So now to have that, you're going to need individual patient information, but you're going to need that information in a way you don't necessarily need the specific identifier of everybody right down to their name, etc., but you do need to have enough information to be able to enable you to be able to draw those conclusions. So that, in a sort of one illustration, is an example of the kind of issues that we're dealing with, that we don't want to have rules that on the one hand would just expose everybody's information. It has obviously huge implications, with respect to insurability. And no question, there are issues about that. On the other hand, you don't want to do it in such a way that's going to prevent us from having better interventions with the power of that aggregate data. So that work is going on now, and that work is going on. There is a working group that involves the provinces and territories, the federal government, the Canadian Institute for Health Information, because as the sort of premier national health information organization, CIHI, obviously has an interest in making sure that we're not going to have the perverse effect that electronic health records are actually going to result in less information being available for them, and Infoway itself is obviously involved, and there are discussions that would take place with privacy commissioners across the country as well.
Thank you. Is there any other comment? Okay, thank you, Mr. Rosenberg. We'll now go to Ms. Washeli-Lees.
Thank you, Madam Chairperson. I want to go back to Dr. Butler-Jones, because the more I ask about the HIV vaccine facility, the more questions there are based on Dr. Butler-Jones' answers. Last May, you brought in a considerable number of experts from around the world to review the 4 bids that were part of this proposal your government had announced in 2007. So in late May, you bring in a large number of people from around the world. Must be fairly costly to do so. Experts, create a review panel to look at the 4 bids. Why would you do a due diligence study after the fact, after the whole process was in place? None of this makes sense. I think you've got to explain to us, you bring in a review panel, you say there's a due diligence study going on, which is at the end of the process. Either we're dealing with, the whole process is just, done on an incompetent basis, or there's some cover-up going on. I mean, it just doesn't make sense. And I think you've got to explain to us why you would bring in these expert reviewers to review 4 bids, all the while knowing there's a due diligence study going on, which is at the end of the process.
You presented 2 assumptions, both of which are wrong. terms of the process itself, at the outset of the process, as I've said, casting about, not just with the Gates Foundation, who, again, the Gates Foundation is probably the largest funder of these kinds of activities around the world in terms of dealing with HIV and a range of health conditions and research, the grand challenges, of which we actually have one based in the lab in Winnipeg, etc. So they have tremendous expertise and access to expertise. So at the outset of this process, the need for a facility to produce trial lots of vaccine was something which was, at the outset of the process, a gap. And that was something that both the Government of Canada and the Gates Foundation were interested in. So we went through that process. It was a transparent process. People had the right to apply. 4 people came forward at the end of the day, were invited because of what they had potentially to offer. And we continued on that process. In May, we brought together the panels, and they identified deficiencies with all of them. So none of them crossed the bar in terms of there was some potential there, but still a lot of inadequacies to be addressed. At the same time, Gates had recognized, and again, because they're involved internationally far more than we are, they recognized that the scope and the sea had changed, the world had changed. And so they commissioned this report that we saw in July. So it was after that part of the process that indicated we had a situation where capacity in the world had changed and that this would not be added value, and we would essentially spend a lot of money for a facility that would not be well used. I'm not sure that's the best use of the resource given all the other things that we need to do. So there is nothing more complicated than that. Evidence came forward. We take evidence as it comes. At the outset of the process 2 years ago, the need was there. In that time, the world has changed. A reassessment of that indicates that, yes, the world has changed, and therefore, given where we're at, we have to reassess it. It's as complicated as that. And I don't think, and as the Chief Public Health Officer, I am not interested in spending money on something that will not be well used, given all the other needs.
But new evidence has come forward, and so now it's important that we ask the questions about whether or not you're prepared to review that evidence and then reconsider the process. First of all, I do want to say that the Oliver Wyman study said at the outset, as Kirsty mentioned earlier, that it was not a complete study, and in fact, quoting from it, it's based on the scope choices agreed upon at the beginning of the project. There are limitations to this study that would require additional research. A very important statement in the scheme of things, especially now that we have very clear research, scientific evidence from Dr. Gearson. This is an expert in the field from whom your government has in the past sought advice, seen as someone very important in the field, who has now confirmed what the Weinman study said at the outset, that it was not complete.
Ms. Walsh, your time is up now. You've got to, Dr. Butler.
My question is, will you therefore now begin the process again and ensure that the 4 bids are given serious consideration?
There are always exceptional views for whatever issue it is. We saw that through SARS. There were experts out there that had very contrary views to my own in terms of SARS and in terms of the H1. I go with not the 1 out of 10. I go with the 9 out of 10. And we've reviewed this, and the point is that you make decisions. If you wait for the 100% answer, you can wait forever. The point is, do we have sufficient information to make a decision based on what we have? And that is our view, that was sufficient information. The Gates Foundation does not feel they need to revisit. We do not feel we need to revisit. That is an individual's view.
1 out of 10.
Around the panel.
Ms. Walsh-Lees, I'm calling you to order. Ms. Walsh-Lees,
Madam, that is
excuse
not
me,
true.
order.
Others have reviewed this.
This is done now.
Would you table the others then?
Ms.
Would you table the others?
All right. Brown, proceed.
Thank you, Madam Chair. I just want to follow up with some more questions on the Canada Health Infoway. And I've got a few questions. In terms of the x-rays that are digitalized, you mentioned, was that only in Alberta or PEI, or do we actually have digitalized x-rays in Ontario? Second question is, we talked about the digitalizing the prescriptions for pharmaceutical products or drugs. Is that taking place in Ontario as of yet? And if not, when can we expect that to take place? How much do we invest into Ontario for the Canada Health Infoway? And lastly, given the concerns we've had in the past few years with how the Ontario government has managed the Health Infoway funds, what monitoring tools do we have to make sure that in future federal dollars are used as efficiently as possible?
Thank you. Well, let me say at the outset, I don't think I have with me all of the specific information that you want, but we will endeavor to get it and to provide it. I can give you a little bit more information. Just to give you an example of things that have been done, in terms of the drug information systems, those are in place in the following provinces: in Alberta, in British Columbia, in Saskatchewan, and Prince Edward Island, so not yet in Ontario, that I can tell you. I know that digitization of X-ray film is underway, as I said, across the country, but is not, I wouldn't say that it's absolutely completed across the country. And again, we will come back to you with specifics on Ontario. And I'm sorry, the last part of your question?
How much do we invest in our partnership with Ontario?
Well, we have provided money to Infoway.
Yeah.
Infoway then provides money to the provinces. The cost-sharing ratio, I believe, is 75 Infoway, 25% provincial, but it is not done, as I mentioned earlier, on an across-the-board basis. Infoway isn't just providing money to everybody. Infoway insists, and this is part of the strength of Infoway, that they have to have a partner in the provincial electronic health record system that actually is ready with a plan that demonstrably can put the system into place before Infoway will flow the money. It is a very strict, gated funding approach.
Do we have any ballpark figure of how much that's resulted in Ontario projects?
I don't have that information. That information is available. I don't have to have it here, but I would be happy to provide it to you as soon as we can.
And the most important question, the last one, is what monitoring mechanisms do we have, given the concern that of the challenges that we've seen in Ontario?
We've had a number of monitoring mechanisms. The most significant is the one that the deputy raised in terms of making sure only projects that actually meet the criteria get funded, which is why it's not a per capita, every province gets their share. It's actually project specific and they have to meet the criteria. And then only when the system is in place and working and actually being used does the remaining funding flow. So there's a significant portion of the funding that's held back, that we use the term gated. But in addition, after following the Auditor General's reports and some of the concerns that have been raised by provincial auditors in the most recent funding that we are flowing to Canada Health Infoway, we have put in some additional conditions, for example, things like some maximums for per daily rates for consultants by jurisdiction, those kinds of things. So there are a number of accountability measures that are in place now with Canada Health Infoway that they, in a sense, pass on to their individual projects. But they've been, for example, the fact that the architecture, the standards have to be the national standards. We do want to be able to have information that is consistent and comparable across the country.
And do we have a list of what projects have met those criteria that you speak of? If we wanted to find out which projects have been approved in each province? Yeah, Infoway would have that, and we can provide that. The other thing I should say about this, this is a multi-year program. If you look at the way governments, both the previous Liberal government and the present government have provided funding, funding has been provided in tranches. So to date, there has been $2.1 billion provided, but not in one big chunk, in chunks of $400 million or $500 million. I think and there is a funding agreement between Infoway and Health Canada. Infoway has to demonstrate that it is actually making progress. There will be more money needed to implement the electronic health record. There's no question about that, given some of the estimates that we've seen
put together. I think it's fair to say that every time we want to see results, and we have seen results to date, we need to keep seeing results from Info and from the provinces in order to keep flowing that money. I think what's happened over the past year with a series of audits, the audits are intended to be helpful in addressing any deficiencies in management practices. As I said, I thought the Infoway audit federally was basically a good news audit. There were some small things that were addressed, a number of other things in the provincial audits, and that will help to move forward to make sure that this is all being done on a prudential basis.
Thank you, Mr. Rosenberg. And we have time now to go into yet another round, and so we're going to do that. I am going to suspend at 11:15 because we're going into the voting on estimates, and I know you don't have to be a part of that. So we'll go into the second round, and it's a 7-minute round. So we will begin with Dr. Duncan.
Thank you, Madam Chair. I really am struggling with this. We put 4 applicants, this is with regard to CHVI, through an expensive process while doing due diligence at the end of the process and not the beginning. I find it highly unusual. And I'm going to pick up on what my colleague, Ms. Washali-Salee, said, which is that Dr. Gerson has been used in the past, and I'm wondering if he was involved in this process.
I'm not aware. Certainly we used a range of international expertise. Again, this is a critique of a study. This is not another study. This is not another assessment. The Gates Foundation and ourselves are satisfied with we have enough information to make the decision. In terms of the applicants themselves, none of them met the bar. There were deficiencies in all of them. I can't go into, obviously, to details for a matter of confidentiality, but the point is that we had a transparent process. We used outside expertise. We used expertise in the government. We used the Gates Foundation and others. So it is a that's the nature of scientific application. I have had proposals that I worked on extensively that were very costly, and they were not funded. That's the nature of the business.
I think we both understand scientific process and how proposals get funded. The question I have, and if it can't be answered today, I would like to know if Dr. Gerson was part of this process. One of the reasons this facility was called for was to have a facility accessible to researchers. The Canadian Association of HIV Researchers have spoken loudly that the need is still there. Why have you canceled this facility?
It is our view that there is capacity out there. It's not specifically in this particular facility, but there is capacity, and it's, as you note in the study itself, researchers have tended to use certain preferred suppliers or vaccine manufacturing facilities. There are others available, so part of it will be matching the researchers to the facilities that are available so that they can get it done.
I think it's really key to know whether Dr. Gerson was part of this review process. And I appreciate that this, it is one study, but I think that really needs to be looked at. Can you confirm that there was a scientific expert review, a steering committee, and a department decision?
I'm not sure what you mean by the question.
Was there a scientific review for this project? Was there a steering committee, and was there a departmental decision?
There was the review committee, as Ms. Washali-Salee identified, that had reviewed it, and all the reviews were discussed in May. There was a steering committee for the whole process, and there was, at the end of the day, the recommendations that came forward, and of the total process that identified that none of them met it, and that following the information from Gates Foundation, that there was not need to proceed.
So did a bid make it? There was a ranking from the scientific committee. Did any of them make it past the steering committee?
None of them, all of them had deficiencies. None of them were able to the way that they were presented, and all we can do is work from the proposals. None of them met all the criteria.
Did anyone make it past the steering committee?
That's just part. That is part. The steering committee is the facilitative committee. That's in terms of the whole process. Okay. The external review and the internal review come together, and none of them were without deficiencies that would allow it to go forward.
Dr. Butler-Jones, with respect, did anyone make it past the steering committee?
That's not a point. I'm not sure, because nobody makes it by until all of that comes together and the decision is made. There was one proposal that was felt that it might have potential but had serious deficiencies. So that means it does not make the bar. At any point, none crossed the bar in terms of being adequate as a presentation to be ready for funding.
Okay. What, if any, political support was there for ICID, which was bidding for CHVI?
I'm not sure what you mean by that.
Was there any political support for...
This was a non-political process.
Okay.
In terms of the agency's role, the other department's role, the review process, it was a non-political process. It was an independent process. What other comments politicians might have is totally separate from the process.
Thank you. And I'm going to ask, what, if any, political support is there for L5L?
L5L is a concept for, and I think the committee is aware of it, is a concept of a different way of doing high-level containment in clinical studies, etc. It's something that we're exploring, what all is might be involved in that, the value of it, etc. So we're still in the development of what might be a proposal.
And before I hand it over to Dr. Bennett, I just want to point out that this is Brain Awareness Week, and that over the next 20 years that brain issues will become the leading cause of death and disability, and I'd like to mention the need for a national brain strategy in this country. And now I'll hand this over to Dr. Bennett.
I guess there's some controversy, particularly in the public health community this week, in terms of the statements of the government ministers. And I guess as a Canada's doctor, I wondered if you would set the record straight as to whether you believe that contraception saves lives.
Clearly, as it relates to maternal and child health, appropriate programs across the spectrum, including contraception, is an important part of public health. Which aspects of that governments choose to focus on and provide any investment in things that make a difference is helpful to the public's health. Public health planning will involve a comprehensive approach, and governments, agencies, organizations, independent individuals focus on different aspects of that. It is all welcome.
Thank you. Monsieur Mello.
Madame la Présidente.
Thank you, Madam Chair. The National Association of Regulation for Pharmacies advised pharmacists to cease selling natural products that have not been certified by Health Canada. So if this certification process had been completed, of course, there wouldn't have been this happening. What was the reaction of Health Canada further to this advice? Because the Order of Pharmacists does not advise its pharmacists on frivolous elements.
They base their recommendations on concrete things. So what was Health Canada's reaction with regard to the advice given to pharmacists, and did Health Canada truly want to find a way to get rid of all ambiguity with regard to what Ms. Boudreau said with regard to DINs and the regulations? Did Health Canada not assess or look at measures to mitigate, or did it not consider temporary measures before the entire certification process was completed? in order to ensure that products on the shelves are indeed safe. I think this is what everybody wants, for consumers to purchase safe products. However, we do not want to unduly penalize the manufacturers and the retailers.
Merci pour votre question, Monsieur Malo.
Thank you for your question, Mr. Malo. Yes, of course, we are very aware of ANORP's decision, the recent decision, as far as the products which formerly had DINs and now have NPNs. In fact, the transition happened very well. It happened over a 6-year period, which was plenty of time. We received many requests or applications, and they were fairly straightforward to effect the transfer, and they were processed within 15 to 20 days, so there was no backlog, and we completed all of the applications we received within the date contained in the regulations, that is by the end of December of last year. As for ANORP's decision, as you said, for us it was clear that ANORP's objective and Health Canada's objective was one and the same. We want the products to be accessible, of course, but first and foremost effective and safe. So we are still working with ANORP. They are represented on our external committee, which I referred to a few moments ago. So we're still working on them to find potential solutions and administrative solutions to apply within our department, and which would allow people to prioritize their applications so they are processed more efficiently. I can also tell you that the improvements we have made in the last 12 to 18 months have clearly helped. If you look at our numbers, you'll see that most of the applications were processed and completed within the last 2 years. So we are keeping up the good work, and we are also working closely with consumer groups who are also represented on our external committee. Might you apply interim or transition measures? Well, we are not thinking about that right now. Were you referring to interim regulations? No. No. At this point here, we are looking at administrative solutions. We've already implemented some of those solutions. As far as the work within the directorate is carried out. That being said, we will see how things unfold, but certainly we are working closely with ANORP to find a solution, and we recognize, as you said, that this might affect the industry. Mr. Rosenberg, a little earlier you answered one of my questions, but I wasn't quite satisfied with it. I'll ask it again so that you can perhaps be a little more specific. The minister before the committee said that by March 31st, she wants to eliminate the backlog. The Natural Products Health Directorate said that it is only beginning to tackle the backlog. On the one hand, there is political will. On the other hand, there are administrative directives within the department. There is a gap or a discrepancy between what the minister is saying and what the directorate is doing. Does this happen a lot? I will try to answer your question, hopefully more to your satisfaction this time. I'll do my best, but perhaps my best still won't be good enough for you. Within this area, we are not only dealing with natural health products, we're generally dealing with health products, and as my colleague David Butler-Jones said, It's a very complex area, and data is changing all the time. Objectives can be expressed, and we might realize that after some time, the context has changed fundamentally. And as a result, we realize we have to do things differently or do something different. This happens. It doesn't mean that there's a lack of communication between the executive and the public service. It means that everybody has to be aware that we are working in a context which is constantly evolving. Sometimes it evolves very quickly. And this is the only explanation I can give to you. And it is probably the same answer or the same explanation which applies to many situations. There is a statement made at the political level, but the public service has to adapt to a changing situation.
Thank you. I'd like to ask another question on the question of the HIV vaccine facility. Why did the criteria change? When the original applications were requested, it was based on the production of on a not-for-profit basis to meet, and as the government itself said at that time, to provide capacity to produce HIV vaccine to be conducted mostly in and for the benefit of low and middle-income countries. Clearly, something happened from the outset, from the initial application process to February of this year, when suddenly it became acceptable for this vaccine to be produced on a private sector basis, since that's the only capacity identified in the Oliver Wyman study.
Yeah, thanks very much for the question. And I mean, these are really, I mean, let's be clear, these are really important issues to be discussed, and I'm quite transparent. I'm telling you everything I know. There is nothing about this which is hidden. And in fact, the criteria at the outset were financial self-sustainability, governance and management, technical in terms of manufacturing and human resources, and global access. And as I've said before, all of the bids had limitations. In terms of when the Government of Canada with the Gates Foundation decided to, a couple of years ago, to move ahead with this as one of the aspects of the CHPI, the decision was that if we were to fund this, we would fund it as a not-for-profit thing. It was not that the whole issue can only be addressed by not-for-profit. Since that time, as I've said, then there was not capacity. There was a challenge of capacity in the world. There is now capacity. The Gates Foundation, as you know, was very much concerned with least developed countries and access for low and middle-income countries. And so they are confident in this, and they have expertise in the international scene that we don't have, and others. And so we look to them, not just to ourselves, in terms of what is necessary.
Thank you. And I do want to refer to the Oliver Wyman study itself when it says that, and I quote, "An open and transparent process to identify a not-for-profit corporation with the expertise to build and operate the proposed facility was launched in 2007 and is still ongoing." So it's clear that there was a change from the original criteria that were given to the bidders from that point to the present. And I think that's a most unfortunate revelation, because in fact it means people went to a lot of work to abide by certain criteria, and then we're told it was over through no fault of their own. And I think they need to have full explanations why their bids weren't accepted. I want to ask, though, how you will in fact meet the if we now have this report from Dr. Gerson who says the capacity isn't there, and we have concerns from the Canadian HIV Association, which says that you can't test a vaccine without a production facility, and this new direction isn't going to provide it. We now have comments from the International AIDS Vaccine Initiative that has said we've had unprecedented advances. The discovery of 2 new broadly neutralizing antibodies by a research consortium led by International AIDS Vaccine Initiative, and the results of a clinical trial in Thailand by the Thai Ministry of Health. So we've got clear developments in the world, And this was all supposed to then come together in terms of this not-for-profit facility in Canada, and it's now gone. And so Canada has a black mark. We've lost an important leadership role, and on top of it all, the world-renowned facility in Winnipeg, which was told by numerous sources that it had won the competition, is now left trying to explain to the world why, with world-class researchers on HIV and AIDS, with a level 4 laboratory, with a world-class institution, that they're suddenly not able to get this win the bid for reasons unknown to them. And I think for the sake of the reputations of scientists, people who have struggled so hard to put together a world-class facility, I think an explanation is owed. And I think, in fact, you know as well as I do, Dr. Butler-Jones, that Winnipeg won the bid, and suddenly new criteria came into play, and in fact, it's for reasons that are unknown to any of us. Something changed, whether it was global drug politics or regional politics or local petty politics. Something happened, and you've been asked to carry the can on this, and you've been asked to try to explain something that is inexplicable. And in fact, I just want to quote from one of the news items on this. It was by Dan Lett, who, as you know, has done enormous in-depth research on this issue. He has said that, in fact, it is also known that the evaluation committee met for 3 days last May to make its final recommendations, and that following that meeting, several sources told ICID, that's the International Centre for Infectious Diseases, that it had been chosen to host the facility. And no one was surprised about that because, in fact, ICID has a record for doing this kind of work, and its proposal was backed by the largest vaccine production facility in the world, Serum, by the largest biotech industry or producer in this country, that's Cangene. It had the backing of the International AIDS Vaccine Initiative. It had the support of numerous universities, including obviously Manitoba and Montreal, and it clearly, as they were told, it met the criteria and then some. So I think explanations are owed to them, and I don't expect I'll get them today, but I will ask this one question. Will this government continue the annual funding of the International AIDS Vaccine Initiative or the International Partnership for Microbiocides, causing and the lack of any news on these fronts is causing both of these organizations considerable anxiety? So I just want to know, will that funding be continued?
Okay, Dr. Butler-Jones, before you answer that involved question, I just want to say this will be the last question. And so following your, I will not be taking any more questions from the committee. Thank you.
No more. I think this conversation will continue. I do need to, in terms of the last question, I'll start there. That's a new question to me. I don't actually have information on that, so we'll have to deal with that later. But I do need to set again to state that some of the assumptions really are wrong. The criteria did not change. If we were to build a facility in Canada, our expectation was that it would be not-for-profit. But the generation of this was not the issue of having a not-for-profit. The generation at the time was that there was lack of capacity. That was the issue. Then the criteria for what would look like for a plant in Canada, that was outlined, and I read that to you earlier, that the criteria were not met. And I don't know who it was said it, or where it was said, or to who it was said, but it was wrong. No one won. No one won. I've seen the reviews, I've seen the original proposals, and there was one which had potential, that's how it was put, had potential, but still had a lot of work to do, so wasn't there, did not cross the bar before it would be acceptable for funding. And it's not that the criteria changed, it's that nobody crossed the bar. And looking forward, it really was, again, the Gates study that identified that capacity, the world had changed. And so in terms of the the capacity out there identifies capacity that sometimes research may not be aware of. So one of the things the Gates Foundation and us, I think, are interested in is matching researchers to the capacity out there to have those things addressed, obviously. And finally, if any of the applicants have questions that still have questions, there have been conversations, discussions, they've had and that will continue. It's really important. If they're not satisfied with the answer, they ask the question, because we're being quite transparent about their proposals, what the issues are. It's unfortunate that none of them cross the bar. It is fortunate that in Canada we will have access, internationally access to new capacity for trial lots, and now we can use that resource for something that will be value added. Thank you.
Thank you, Dr. Butler-Jones, and I want to thank our guests who came today to answer the questions. We appreciate that so very much. I thank the committee for their insightful questions as well. So we will suspend for a couple of minutes and then go into the voting of the estimates. Thank you.